When vomiting during pregnancy becomes excessive enough to cause weight loss, electrolyte imbalance, nutritional deficiencies, and ketonuria, the disorder is termed as hyperemesis gravidarum. So, this disorder occurs approximately 0.5% of all live births. So, hyperemesis gravidarum usually begins during the third trimester, but approximately 10% of women with the disorder continue have symptoms throughout the pregnancy. The woman with hyperemesis gravidarum usually has significant weight loss and dehydration. She may have dry mucous membranes, decreased blood pressure, increased pulse rate, and poor skin sugar. Frequently, she is unable to keep down even clear liquids taken by mouth. Laboratory tests may reveal electrolyte imbalances.
For its pathophysiology, there are different theories postulated on the occurrence of hyperemesis gravidarum. The first one is the endocrine theory, which states that high levels of HCG, or the human chorionic gonadotrophin, and estrogen during the first trimester of pregnancy causes the severe nausea and vomiting, which then leads to hyperemesis gravidarum. The next one is the metabolic theory, which indicates that there is a vitamin B6 deficiency. And since vitamin B6 therapy is indicated as a treatment for hyperemesis gravidarum, it is believed that women who suffer from this disease have low levels or lacks vitamin B6. The next is the psychological theory, which states that psychological stress increases the occurrence of the symptoms of hyperemesis gravidarum. Thus, if a pregnant client stresses about a lot of stuff, then hyperemesis gravidarum may occur. And for the diagnostic findings, it is important for us to watch out for these. First one is the liver enzymes, specifically the aspartate aminotransferase and alanine aminotransferase, which are both elevated during the occurrence of hyperemesis gravidarum. And this can also be an indication of an underlying liver disease. The next is the complete blood count, which indicates that the elevation of RBCs, or red blood cells, and the hematocrit indicates hyperemesis gravidarum, because this leads to dehydration and severe nausea and vomiting. Next is the test for the presence of ketones in the urine. Since a pregnant client suffering from hyperemesis gravidarum cannot ingest as much as food as she needs, the body breaks down stored fat in order to use for energy. And thus, as a product of fat metabolism, ketones will be positive or will be present in the urine if the client is suffering from hyperemesis gravidarum. The next is the test for the blood urea nitrogen, or the BUN. Since in hyperemesis gravidarum, there is a presence of water and salt depletion, then BUN levels will be elevated. Moreover, this can also be an indication of an underlying kidney disease. Next test is for the urine-specific gravity. If it is greater than 1.025, this is an indication of a concentrated urine due to severe nausea and vomiting, thus indication of the presence of dehydration. Moreover, this can also be an indication of ketonuria or even severe fluid loss. Next is the test for serum electrolytes. Decreased levels of potassium, chloride, and sodium during hyperemesis gravidarum is an indication of severe fluid loss. This is due to excessive vomiting and loss of hydrochloric acid in the stomach. And lastly, we have the ultrasound, which can be used to check if there is the presence of molar pregnancy or multiple gestations.
Treatment and medication options for hyperemesis gravidarum. Hyperemesis gravidarum is the second leading cause of hospitalization in early pregnancy, and the treatment for hyperemesis gravidarum varies from person to person. Your doctor may recommend one or more of the following. First is the vitamin B6. Next is the small frequent meals that include dry bland foods such as crackers. Next is the intravenous fluid. electrolytes to help with dehydration. For severe cases, parenteral nutrition, in which an intravenous IV solution of vitamins and nutrients is given as a substitute for food. Next is the acupuncture and acupressure. And lastly, the ginger taken in tea or through a capsule. Alternative and complementary therapies for hyperemesis gravidarum. Evidence concerning the effectiveness of the following therapies for hyperemesis gravidarum remains inconclusive. But when we use in addition to traditional medical interventions, they may help alleviate symptoms, and it includes hypnosis and the light therapy. The light therapy used to help with the depression. But note, before trying either of the mentioned, make sure to discuss their use with your healthcare provider.
The initial pharmacologic treatment for hyperemesis gravidarum is the combination of doxylamine and pyridoxine. Pyridoxine, or vitamin B6, is given because it is effective in significantly reducing severe vomiting. Additional medications include ondansetron, which is an antiemetic drug that will prevent or treat nausea and vomiting.
Next is the nursing management. So first, assess for vital signs. Heart rate, respiratory rate, blood pressure, and get baseline vital signs and take note for any changes because tachycardia, hypotension, and tachypnea can occur. Next, assess for dehydration. Patient can lose many fluids from vomiting or inability to take oral fluids. Next, monitor intakes and outputs. Monitor urine analysis of blood and take note for dark urine and decreased outcomes that indicates renal function impairment. And next, assess for and treat constipation as necessary because it decreases intestinal motility and administer stool softeners as appropriate.